For so many years, right? HIV back in the day was a death sentence for people.
Antiretroviral therapy came out in the late 95, early 96. It really revolutionized HIV care.
There's a measles outbreak.
I think people have forgotten how deadly diseases like measles, mumps, and rubella can be. They can kill people, as we've seen already in Texas.
All right. We're going to get to all of that in just a moment. But first, I want you to know how grateful I am for today's podcast sponsor, my friends at FitAF Nutrition. They are Eastern Pennsylvania's leading meal prep company. FitAF offers meals of multiple sizes for people with various health goals. And you know what I love about this company? They use high-quality ingredients like grass-fed meats, wild fish, and locally harvested produce. And all right, for you parents on the go, they even offer family meals. Go to fitafnutrition.com, place your order by Thursday at midnight, and get fresh, prepared meals delivered right to your door on Sunday.
Use code Leckey20 at checkout to get 20% off your first order of 7 meals or more.
Here we go, buddy.
It's the Ryan Leckey Show.
Great to have you back for another episode of the Ryan Leckey Show. And look, today we are talking about something that could make a lot of you uncomfortable. It's sort of a topic that a lot of people don't like talking about, but I think we need to dive into it. We are chatting about STDs and HIV, and specifically the rise in cases, not only where we're based in northeastern and central Pennsylvania, but all over the country. So what's going on, and what are things people can do sort of to help mitigate all of that? Somebody who's joining me, who this is definitely her wheelhouse, is Dr. Shubhra Shetty. She is an infectious disease specialist, board certified, 26 years, and you are the medical director of Xceed in Scranton. So before we dive into some of the facts, let's just talk about the organization that you oversee now. What do they do, Xceed?
Ryan, thank you so much for having me. It's really nice to be able to have a conversation about a difficult topic. So to tell you a little bit about Xceed, it was previously called Wyoming Valley AIDS Council, and it's been in existence for about 40 years in the Wilkes-Barre-Scranton area. It started off as a community organization where people came together to sort of mitigate some of the effects of HIV/AIDS. And gradually the organization grew to get more funding and to provide more support services. And finally, over the last several years, we are providing direct medical care to people living with HIV/AIDS, with STIs for prevention, as well as other infectious disease services. We're a nonprofit, and we have 3 office locations which are based in Scranton, Wilkes-Barre, and Hazleton. But we actually cover 6 counties of Northeast Pennsylvania, so quite a big catchment area. And we provide a lot of support services like the direct medical care, case management services, mental health services, particularly towards patients who may be at risk or may be living with HIV.
Yeah, and this is provided at little or no cost to patients.
Yes, so we are a nonprofit. As I said, we have what's called Ryan White funding, and we take people who have access to very limited healthcare, so free testing for STIs, etc., through the Department of Health. We have folks who are insured and have excellent insurances, so really all comers.
Okay.
We're just there to provide care to people.
And why we're chatting about this today, right? You have been a board certified infectious disease specialist for 26 plus years. And you would think with modern medicine and everything rolling out that we would see fewer cases of STIs as well as HIV. But that's not the case, not only in northeastern and central Pennsylvania, but across the country. So why the spike?
Yeah, that's a really interesting question. So we are seeing a decrease in HIV infections through the country overall. However, in northeastern Pennsylvania, we actually have seen a spike in cases of HIV in the last year and a half, particularly. Also, we're seeing an increase in traditional STDs, such as syphilis, gonorrhea, and chlamydia throughout the country, and as I said, and locally. I think to some extent, it could just be that sometimes the fear of getting STDs has diminished. There may be less knowledge about the fact that these diseases still exist. People aren't talking about it as much anymore. Probably the COVID pandemic contributed in some way because there was decreased testing and treatment of people who were living with these illnesses, so they didn't have access. So that probably contributed as well. So there's many different factors that go into this increase in traditional STDs, if you will, as well as HIV infections locally.
And who are the people being diagnosed with, STIs, STDs, HIV cases? I think forever there's a stigma that HIV only impacts gay men, but your organization, right, lives and breathes this every day, treating a number of people. Who is it?
We are diagnosing STIs as well as new HIV infections in really the full gamut of people that we see. Anywhere, so we only take care of adults. So literally from the age of 18 onwards, my oldest patient is probably is actually in his 90s. So really anybody could be at risk for HIV infections as well as STDs if you're sexually active, or frankly have been sexually active in the past. You could be at risk.
So this is heterosexual people too.
Absolutely. Yes. We are seeing, unfortunately, we're still seeing young women. We're seeing pregnant women who pop up upon routine testing. They pop up as being HIV positive. We have people who may have symptoms or not have symptoms. Because remember, some of these diseases may not cause symptoms right away. So they're causing damage in the body, but they haven't caused any symptoms. So people may not know that they're infected. They may not know that they are carrying one particular STD or HIV infection. And so that's how spread can occur, because they just don't know.
So when you hear that people might be living with HIV and don't even know it, like at what point do you say, this is the demographic of people who should be getting tested? Is it people who've been in long-term committed relationships, or is it people who may have various partners?
Yeah, so, what you're really asking about is what we call risk stratification, right? So essentially, if you think about it, everybody should be screened at least once for HIV. So the CDC recommends that everybody who is anywhere from the age of 18 to 64 should have at least one HIV test in their lifetime. Okay, so think about it, that the recommendation is that really everybody should be screened. Now, who are the people who are at increased risk, right? That's another way of asking that question. So really, anybody who's sexually active, like I mentioned, especially women under the age of 25 who are sexually active, should be screened for the traditional STDs. Anybody who's in who has multiple sexual partners, they do not use protection consistently, should be screened. Anybody with symptoms should be screened for STDs as well as for HIV. Anybody who's worried, anybody who's pregnant, so increased risk. So there's many different reasons that people should be getting screened. The bottom line is, if you're worried about it, or if you're even thinking about it, you should probably get tested.
For so many years, right, HIV back in the day was a death sentence for people. What's changed with modern medicine for people being diagnosed like the folks you're talking about?
Yeah, that's a great question. So I'll share with you that when I was in my internal medicine training in New York City many moons ago, HIV was kind of a death sentence. And sadly, we saw a lot of people dying of HIV, AIDS, and related complications. Once medicines came out, what we call antiretroviral therapy or highly active antiretroviral therapy came out in the late 95, early 96. It really revolutionized HIV care. And we are now at a point where we are able to treat people with very simple medications that are easy to tolerate, and people do well with them because it's one pill once a day, oftentimes, is what we're able to give people. with very few side effects, very few what we call drug interactions. There are some injectables now that are available if people prefer that. So the options have improved and people do remarkably well. The current thinking is that if you're diagnosed with HIV early, you should be having a near normal life expectancy. Just think about it, how remarkable that is. And connected to that is the fact that if somebody is on treatment and doing well, what we call an undetectable viral load, then their risk of transmitting to others goes down to essentially zero. So it's not only about treating the individual who has HIV infection, but it's also to diminish spread of HIV to others. So that's been revolutionary in terms of providing care to people with HIV.
So that's the treatment. What are the preventative drugs out there that have helped kind of change the game or maybe have helped those folks who are sexually active with multiple partners?
So if somebody is at very high risk, and I sort of alluded to that a little bit earlier, that folks who have, say, they are sexually active, but they have, they're not using protection. They are living with somebody who's HIV positive, who's not undetectable. People who may be engaged in commercial sexual activity or exchanging sex for drugs or money, etc. So people who are at extraordinarily high risk can protect themselves with certain medications. And now they can take a pill every day. Or there's an injectable option as well that can be taken every 2 months. And that's very effective in terms of preventing them from getting HIV. I do want to mention that in addition to that, we shouldn't forget barrier methods like condom use, both for men as well as for women. We need to think about, simple things like male circumcision actually decreases the risk of acquisition of HIV. So, and I mention that because when you talk about an epidemic like HIV, it's not just here in this country or locally, it's all over the world. So we need to sort of think about it globally because as we know well, what happens in the rest of the world affects us locally as well, right? These diseases can spread very easily. So we must keep in mind the bigger picture and think about folks that are affected all over the world.
So what's the medical protocol if somebody is on an HIV prevention drug, such as PrEP? How often should you be tested for HIV as well as STDs?
Yeah, so the recommendations are that, remember, PrEP or pre-exposure prophylaxis is only meant for people who are HIV negative, right? So you have to be, you should not be infected with HIV to qualify for getting PrEP. So thinking that they're at higher risk, we screen people before we start medications for HIV as well as STIs. We also do regular blood work to make sure that it is safe to have these medications. And then usually every 3 months, they are tested for HIV as well as for STDs. We also check their kidney function to make sure that's normal. So periodically, there's a protocol in place so that people are tested on a regular basis. The idea being that if indeed they developed a problem in between, that can be picked up quickly and treated. One other thing I would add is that if somebody has symptoms in between that period, so suppose they have a discharge or they have fevers and lymph node enlargement and so on, in between, I encourage them to come in for earlier testing. So the standard is every 3 months, but it doesn't mean that they can't be tested more frequently if it's indicated.
So when we hear about all the preventative drugs out there, right, to help, the HIV drugs to help those who have been diagnosed, do you think we're getting closer to a cure? Like, what does the science say? Like, it's like we haven't had a vaccine yet to just eliminate it.
Yeah, it's a great question. So one way of thinking about this is what we call a functional cure, which is let's take the analogy of diabetes, right? So if somebody has diabetes, they're on medications and the sugars can be controlled. And you aim for a hemoglobin A1C of, let's say, 7 or lower in many people. So in HIV, what we're aiming for is, of course, to keep the individual healthy. Finally, that's what it's about. And then we aim to keep the viral load or the amount of virus in the bloodstream less than usually 20 is what's considered undetectable. So you want to aim for a viral load that is so low that on testing it cannot be found. And that then allows the immune system to build up or to stay healthy and people to stay healthy over a long period of time. So that's sort of one of the markers of keeping people healthy and safe. The good news is that if you keep an individual healthy, as I mentioned, healthy and undetectable, they do not then transmit virus to anybody else. So the way to eliminate HIV, sort of big picture as we see it today, is test people at risk, right? If they're positive, they get diagnosed and they get on treatment, and then we keep them on treatment by making it an inviting, non-judgmental environment so people feel comfortable getting treated, manage any problems that come along the way, keep them healthy, provide them the support they need, such as housing, food, and dealing with food insecurity, etc., right? The sort of the social aspects of care. The folks who are HIV negative but are at high risk should be given PrEP, pre-exposure prophylaxis, so they stay negative. As we do that more, eventually the virus transmission can go away, right? Just if you think about it, you diminish the source and you decrease the way that people can get the infection. So with time, you could have an end to the epidemic. We're not there yet. And I'm also hoping that along the way, new advances come along. There may be new technologies that get developed. There are trials going on as we speak about vaccines, about different techniques to try and eliminate HIV infection, but we're not there yet.
Let's talk about the stigma around HIV. It's 2025. Has it changed in 2025 from where it was decades ago? And what are some of the myths that you want to bust?
I would say the stigma has diminished, but by no means has it gone away. I think the stigma has diminished in the sense people are able to talk about HIV. It's more open. There are ads on television about medications, right? But what I see is, and especially in, let's say, where I practice, which is Northeast Pennsylvania, there is still a lot of fear about people finding out about an HIV diagnosis, and it's quite stigmatized. There is still this wariness about how HIV is spread, about who has it. You must be a certain way to be positive. So there is still a lot of stigma, and patients talk about it all the time. There is a fear of being labeled as being HIV positive and what it means for themselves, for their families, for their loved ones, for friends. So by no means has it gone away.
Talking about HIV myths, right?
Yes.
If we wanted to bust some of those, what are people still getting wrong about the virus? So if somebody knows someone who's been diagnosed with HIV, right, what are people missing? What are the myths that you're like, this is not facts, this isn't factual?
Right. I think there are several myths. One is people don't think it's there anymore. I think that's one of the biggest myths, that people think it's just not a thing. That, nobody's talking about HIV anymore. We are, and I hope to build awareness about the fact that this is still very much an issue. And like I said, we see people getting diagnosed, unfortunately, with new diagnoses on a regular basis in our own community. The other myths are how it's transmitted. So HIV is not transmitted by casual contact. It is not transmitted by sharing a cup of coffee with somebody, or by kissing, or by just sort of holding somebody's hand. It has to be much more exposure than that. Usually, sexual exposure, or sharing needles. Say people who use drugs and are sharing needles. So those are some of the ways that it can be transmitted. So, I think there's a lack of awareness about the fact that it's still there, it's still real, and it still can really hurt people. It changes people's lives to find out that they're HIV positive, because suddenly, it's something you don't perhaps want to talk about with your neighbors. You have diabetes, you may be more comfortable talking to friends, family about your diagnosis of diabetes.
Because it doesn't have the stigma that HIV
It doesn't have the
does.
stigma.
Yeah.
So there's also a lot of, I think, loneliness. There's a lot of, diminishing of supports that can come with a diagnosis like that.
And do you think some of those myths fall into, I think, the public just thinking, oh, it's only a certain group who gets HIV?
100%. I think that it's all intertwined with stigma, with I'm not at risk, so I don't need to worry about it. And remember, we're in the age of dating apps and social media, where having more casual, perhaps sexual contact has become easier, and so people aren't thinking about it. So you asked me in the beginning about why are we seeing an increase, and changes in social behavior related to the fact that people are sort of hooking up or are having perhaps more anonymous sex, is also contributing to the spread of these diseases.
What's the one thing that you feel everyone should just know in general about HIV right now in 2025?
I would like people to get tested and treated, and if they're negative, if they're positive, they should get treated. If they're negative and they're at risk, get tested and be safe. There are tools that are available now that were not available in the past, in the sense that there are medications that people tolerate well. The one other thing that's related to this is that there is good care, non-judgmental, highly professional care available in this community, and it's completely confidential.
Yeah, and I think that's the one
much
thing.
of it is free,
Right.
that you can get tested and treated, and we really try to make it as pleasant an experience for people as we can, because it is scary. It's really scary for people to take that first step and to come in and get tested.
Well, especially when you said the CDC recommends that people, is it 18 to 65?
Yeah, so basically
should be having an HIV test
at least once in their lifetime.
Once in their lifetime.
At least once.
And there's a lot of people who don't do that.
And people who
Yeah.
are at risk really should be tested more often. So if you are high risk, and we talked about some of the folks who are,
It doesn't matter if you're gay, straight, however you identify.
Yeah,
the
so-
CDC recommends you should be getting tested.
like
once.
I said, at least once.
At least once.
And if you're higher risk, so if you have a sex partner who has HIV or may have HIV, if you're having anal or vaginal sex in the last 6 months and not using condoms consistently, you're very high risk. If you were diagnosed with an STD in the past 6 months, you're considered very high risk. If you're a drug user, you're considered high risk. So those individuals need to be tested more frequently. So everybody should be tested at least once, but people who are at higher risk, just go get tested. It's simple, it's quick, it's confidential, and frankly, it's often free.
But Dr. Shetty, I think what's interesting for the nonprofit organization you work for, Xceed, right, that has 3 offices in northeastern Pennsylvania, this is sort of like your wheelhouse. Do you feel, even in 2025, some medical professionals are not having these conversations with their patients and they're not as educated as they could be to provide that comfort level to some of their patients to talk about this? Because I've known people who were like, I asked my doctor about PrEP or that, and they like, why do you want to get on? What's this about? Why do you want to get on that?
Yeah, I think there is often discomfort around asking a sexual history. Patients don't want to volunteer that they're at high risk. Providers have many things that they are dealing with. They're, as healthcare has changed and there's a gamut of things that need to be addressed in a short office visit. I think perhaps sometimes issues like this don't get addressed as much as they could be. I think that's why places like ours exist, because we are very comfortable with our patient population, we're comfortable with testing, treating, we're set up for it, perhaps more than some of the other offices. I think there's just, in modern healthcare, there's just so many things people deal with. And times are short, people may not be delving into some of these risk factors as much as they could.
Right. Especially, we know, right, with healthcare these days, a lot of people are unhappy the way things go, right? People feel like they're just rushed in and out of an appointment, right? And, I've known a lot of medical professionals who sort of, they have X amount of patients they got to see a day. So then that's why I feel like some of these conversations aren't coming up. And they should.
Yeah. Yeah, I think it's also some of these strategies are newer and may not have percolated as much in general practice just yet. So conversations about PrEP, conversations about, the different strategies that are now available, and also lack of experience with using some of those medications. So, there's a wariness around using certain medications because that's not what you do every day, right? There's a, if, oncologists give chemotherapy on a regular basis, first of all, I shouldn't, and I wouldn't give even, if you will, the mildest form of chemotherapy to somebody, because that's not what I do. That's not what my expertise is. So I think there's a little bit of that. There's just not the comfort using these medications. Infectious disease specialists and others who do HIV care, for instance, have been using these medications for a long time, and those meds are now used for prophylaxis or PrEP. So I think we have many years of experience with not just using the medications, but to watch for side effects and counsel appropriately and so on. So I think that's part of what might be going on.
Okay. And before we wrap, I just want to pivot to another topic, because I wouldn't be doing my job if I didn't ask you this. Somebody who's board certified, 26 years as an infectious disease specialist. COVID. Are we out of the biggest dangers of COVID? What is your recommendation as an infectious disease specialist with vaccinations? Because this is still a topic that is hot in America,
Yeah.
and it still has people divided.
Yeah, so, I think when COVID hit in early 2020, nobody had exposure to that virus. So anybody who got exposed to that particular infection could get quite sick with it, so there was no immunity to it. It was revolutionary that a vaccine came out as quickly as it did and was able to protect people from getting serious infection. The COVID vaccine did not prevent infection per se, it prevented the effects of the serious forms of the infection. And as time has gone on, people have either been vaccinated or they've had COVID or both. So they have protection, they may have antibodies to COVID. So COVID, if you will, has lost its bite to the extent that it did before. Having said that, if a person is very immunocompromised, has a very diminished immune system, or is at very high risk for getting serious COVID, they should probably still be getting vaccinated. And frankly, anybody who wants to should get vaccinated. Probably the highest effects of the vaccine were the initial few doses, right? The first couple of doses and even a few after getting the boosters, because the virus was changing all the time. So if you remember, the Omicron variant was acting differently, was able to make people sick even though they had been vaccinated, right? So the booster came out for that. I think now so many people have already either been vaccinated or have had the infection that even though COVID activity is still around, it's not making people nearly as sick as it did. So oftentimes it's like a mild cough, cold kind of symptom complex. But like I said, if people are somebody who's very immunocompromised or very high risk for complications, they should probably still get the boosters.
So you're saying, though, for people who maybe aren't at high risk, if you had the vaccine twice, you had the booster, the research is showing getting another COVID vaccine, there's not a significant increase in protection?
I never stop people from protecting themselves. But I think the benefit of getting additional vaccinations as things stand right now are not as much as they were in the beginning, let's just say. So the early vaccines, when people got vaccinated early on, you had no protection. Now most of us have a degree of protection. So the benefit of getting the vaccine is not as dramatic as it was in the beginning. Does that make sense?
Yeah.
So,
And I think if you're ever confused, talk to your healthcare provider.
absolutely.
Definitely.
Absolutely.
And with this talk about infectious diseases, I'd be remiss if we didn't mention at the time of filming this in 2025, there's a measles outbreak. What's your take on, that outbreak happening and the buzz about vaccination as an infectious disease specialist?
Yeah, so I think people have forgotten how deadly diseases like measles, mumps, and rubella can be. They can kill people, as we've seen already in Texas. The vaccination is very safe. It's been around a long time and probably has saved more lives than we can even imagine. And it's not just saving lives, it's also side effects, such as side effects of getting infection, deafness, encephalitis. There are many other diseases that come with complications that can come from measles, rubella, etc. Rubella can cause miscarriages in pregnant women if they're exposed. So these are highly infectious diseases and can spread very, very rapidly in an unvaccinated population. The vaccine is a simple vaccine. It's a two-dose vaccine, highly effective.
If you had it as a kid, because I believe I did, if you went to a public
Yes.
school, you had to have that. Do you have to get it again?
So probably most people do not need to get it again. Again, if somebody's we still see people who did not get it in childhood, and we do recommend it. But most folks who went to school in the US, if they didn't have an exemption or whatever, probably have been vaccinated. If you're in doubt, talk to your healthcare provider and get tested. The titers can be tested. And if you have low titers, you can definitely get a booster. So, I think that these vaccines have saved and will continue to save many lives and continue to save a lot of morbidity and heartache. We're already seeing the effects of measles spreading in an unvaccinated population. in many parts of the country. And measles spreads so quickly that, we say that if there's, say, a child with measles in a waiting room and the child leaves, so somebody else comes in a couple of hours later, unvaccinated, they can still get the infection from that exposure.
Wow.
So it's highly infectious. And again, if the population is vaccinated, then that spread doesn't occur, right? So even if they're exposed, if you've been vaccinated appropriately, you're not going to get in and you're not going to spread it to anybody else. So again, that concept of, herd immunity. But, you're seeing the consequences of low vaccination rates as we speak.
You're a wealth of information. Before we go, any final thoughts? I mean, we talked about the increase in STI, STD, diagnosis, not only in northeastern and central Pennsylvania, but across the country, the increase in HIV diagnosis. But there's a lot more help available now more than ever. Any takeaway that you want people to know, especially with Xceed, the nonprofit that you're a part of in Scranton? I mean, that's just doing a lot of work in addressing this topic and these, I want to say, concerns of people that a lot of people don't want to talk about because it is uncomfortable.
Yes.
Final thoughts.
It is, these are uncomfortable things to talk about. And, it takes courage for people to sort of take that step and get tested and to sort of, make that appointment, get tested. But just knowing that there is help out there, there are appropriate treatments out there that are pretty simple and easy to take. And, one thing we didn't touch upon was sort of something newer, which is called doxycycline post-exposure prophylaxis.
Right. So you have PrEP, which is what people are taking to prevent HIV.
Correct.
Once they've had the blood test that they're HIV negative.
Correct.
That's the preventative. What is doxy-PEP?
So doxy-PEP is basically taking a common antibiotic called doxycycline, taking 2 doses if somebody is at very high risk for HIV, particularly if they are men who have sex with men, because that's where it's been tested, to take 2 tablets of doxycycline, 200 milligrams, within 72 hours of unprotected sex. And that has been shown to decrease acquisition of syphilis, chlamydia, as well as gonorrhea.
Significantly?
Significantly.
But do you think people are utilizing that as a fail-safe to not wear protection?
Maybe. As research has shown that a lot of folks who say that they're using protection condoms to their doctors, people who are saying to their doctors that they're using protection, often don't. Some people are very good about using protection, but there are others who use them not always. So it's for those encounters, and ultimately, we have to meet people where they are. We counsel everybody to be safe, to use condoms, but this is also a backup so that you do not get sick. Do not get syphilis, gonorrhea, chlamydia. Because remember that if you are in a social network or in an area where there's a lot of diseases going around, you're more likely to get them. Right?
And is it a certain demographic, race?
So it's basically anybody who's having unprotected sex. As I said, the sort of high risk criteria is at risk. At this point, doxy-PEP is approved for men who have sex with men. So that's sort of where the studies were done. Mm-hmm. There are other studies underway to see if there can be an expanded use, but these are relatively new data. You asked about Xceed, and just know that we are here. We have an office in Scranton, Wilkes-Barre, Hazleton. They said we cover several counties. And apart from direct medical care, we're also providing support services such as case management to help people navigate healthcare systems, assistance with, insurances, with medication programs called special pharmaceutical benefits, housing benefits, mental health benefits, really sort of surround care to assist people living with HIV/AIDS to have successful lives, to live healthy lives. So I think, that's an important thing. Our case managers are doing groups, are doing educational activities to pay for patients to sort of so that they learn more about how to live well. So that's sort of what the organization does in a nutshell.
And if you're wondering how do I contact them, I would just tell people to Google Xceed,
Yes.
Scranton, or the other areas you mentioned, Xceed.
Correct.
And it was formerly known to many as the Wyoming Valley AIDS Council.
Yes.
So, and then you can find the support.
Absolutely. And I just want to emphasize that we do a lot more than HIV and STD care. That's a huge focus, but by no means is that the only services that we're providing. So coming to the office does not mean that somebody should feel stigmatized in any way about what problem they might be coming in with.
Good to know. You're a wealth of information. Well, 26 years as an infectious disease
That's
specialist. Right. So thank you so much for your time. And I really hope this is eye-opening for a lot of people, because I think really the big Easter egg you hit on, right, that is backed up by the CDC, whether you had two partners, whatever, however you identify, straight, gay, whatever that looks like for you, the CDC recommends you should be getting tested.
Yes.
For HIV.
Correct.
And obviously more frequently if you're more active, not using protection and everything else.
That's correct.
All right.
Yep.
Thank you so much,
Great.
Dr. Shetty.
Thank you so
from
much.
Xceed. I mean, your nonprofit's doing a lot of amazing things, specifically in northeastern Pennsylvania. I know similar groups do this around the country, but I think people need to know about them, know that there's help out there, and I think even more specifically to be able to go to a team where people can feel comfortable and having these conversations that can sometimes be awkward. I have to say, for me, having these conversations that we talked about, even the STD angle, I had a great health and phys ed teacher in high school who made it normal and comfortable for our age to talk about it. And ever since then, it's sort of like, this is something people are not comfortable talking about, but they should, especially, if they're hitting all the marks you talked about.
That's right.
So thanks again.
Well, thank you so much for having me.
All right. And thank you for being a part of this episode of The Ryan Leckey Show. I appreciate you being here, and I'll see you next time.
Here we go, buddy.